السلام عليكم طلبتنا الأعزاء، وياكم دكتورة زينة عدنان. محاضرتنا اليوم neuro-ophthalmology part 2 will be about the three cranial nerves that supply the extraocular muscles, the third, the oculomotor nerve, the fourth, trochlear nerve, and the sixth, abducent nerve. Starting with the third cranial nerve, the oculomotor nerve. The nucleus is located at the level of the midbrain, at the level of the superior colliculus. بالحقيقة the oculomotor nerve have multiple nuclei حننطيها الاسم oculomotor nuclear complex. يحتوي على unpaired nuclei and paired nuclei and the parasympathetic Edinger-Westphal nucleus. The unpaired this nucleus supplies the levator palpebrae superioris bilaterally. The other supplies, as we said, the superior rectus, inferior rectus, medial rectus, and inferior oblique. The Edinger-Westphal nucleus, which is a parasympathetic nucleus, give parasympathetic fibers that will travel along the nerve and reaches the pupillary sphincter and the ciliary muscle. The nerve along its course, usually it is alone in most of its course, except when it enters the lateral wall of the cavernous sinus, where it is accompanied by the other fourth and fifth and sixth cranial nerves. So a lesion, as we said before, any lesion causes damage to the cavernous sinuses, usually causes multiple cranial nerve palsies. So it supplies all the extraocular muscle except the lateral rectus and superior oblique, and as you remember, the well-known abbreviation for LR6 and SO4 will make you remember this. LR6 يعني lateral rectus supplied by the sixth cranial nerve, and SO4 يعني superior oblique is supplied by the fourth trochlear nerve. This schematic drawing explains important anatomical relationships of the oculomotor nerve. As you can see, when the nerve emerges from the midbrain, it passes between two important vessels, inferiorly the superior cerebellar artery and superiorly the posterior cerebral artery. And then it passes parallel to and lateral to the posterior communicating artery, which is part of the circle of Fullis. The important anatomical relationship here is that the nerve is usually almost parallel to and slightly inferior to the posterior communicating artery, which is commonly affected by aneurysms. So, posterior communicating artery aneurysms are common and important causes for injury and damage to the oculomotor nerve. Also, we have the trochlear nerve, the fourth cranial nerve. Also, it passes between the superior cerebellar artery inferiorly and the posterior cerebral artery superiorly, but it is lateral. It is away from the posterior communicating artery. That's why aneurysms of the posterior communicating artery are common causes for isolated third cranial nerve palsy. This slide will explain the pathophysiology behind the medical causes for third cranial nerve palsy and surgical causes for third cranial nerve palsy. As you know, the parasympathetic fibers, we said they are located superficially in the nerve. And the superficial fibers of the nerve are supplied by the pial vessels, while the core of the nerve or the inner fibers are supplied by the vasa nervorum. So the pial vessels are mostly affected by any lesion causing pressure on the nerve superficially, like aneurysms, especially aneurysm of the posterior communicating artery, or tumors. These two factors, aneurysms or tumors or any space occupying lesion causing pressure on the pial vessels or directly on the superficial part of the nerve, will cause early damage to the pupillary fibers because the location of the pupillary fibers is superficial in the nerve, especially superomedial in the nerve. As you can see, the bundle highlighted in green represent pupillary fibers. So pressure on the nerve will cause damage to the superficial fibers first and to the superficial vessels, which are the pile vessels. This is the whole representation of early damage to the nerve where there is mild ptosis, mild exo, but beginning of mydriasis. This we call it surgical third, and the workup should be immediate neuroimaging in the form of MRI and MRA. While medical causes like diabetes, hypertension, hyperlipidemia, the pathophysiology is the vasculopathy affecting the vasa nervorum. The vasa nervorum, which supplies the inner fibers, that's why when there is damage to the third cranial nerve involving the vasa nervorum, which we mentioned the medical causes, the innermost fibers of the third cranial nerve بالبداية طبعا هذا بدنا نحكي بالبداية they will be affected. So the patient will present with complete severe ptosis, profound exotropia because only the lateral rectus is working now, the medial rectus is totally paralyzed, but with normal pupillary size because the superficial fibers are supplied by the pile vessels, which are not usually affected by the vasculopathy of diabetes, hypertension, and hyperlipidemia. So this is the cornerstone differentiating feature between medical causes and surgical causes of third cranial nerve palsy. So summary for the causes of third cranial nerve palsy: microvascular, we said diabetes, hypertension, aneurysms and mostly posterior communicating artery aneurysms, trauma, whether direct or indirect injury, tumors, usually uncommon to cause isolated third, but it is possible, and 5 miscellaneous causes. اكو idiopathic, يعني the cause is not figured out until this moment. Inflammatory causes, ممكن any inflammation, autoimmune diseases, يعني ممكن involvement of the third cranial nerve by, for example, sarcoid granuloma. This may involve any cranial nerve. Migraine, the type we call it ophthalmoplegic migraine, etc. This is a coronal section involving the cavernous sinuses, and as you can see, because all the cranial nerves here, the third, fourth, the first and second division of the trigeminal and the sixth are close to each other, so lesions in the cavernous sinuses or around the cavernous sinuses causes multiple cranial nerve palsies. For example, there are certain granulomatous inflammations involving the cavernous sinuses, cavernous sinus thrombosis, ممكن aneurysm of the internal carotid artery, fistula of the internal carotid, or meningiomas involving the sphenoid bone, tumors of the chiasm, pituitary tumors or pituitary apoplexy. All of these could be causes of multiple cranial nerve palsies. This drawing represents the indirect effect of trauma causing extradural hematoma, and this leads to uncal herniation, which will cause pressure on the third and sometimes also the fourth cranial nerves as they pass near the free edge of tentorium. So a trauma may cause direct damage or indirectly, as we can see when subdural hematoma causes uncal herniation. The clinical features is obvious: ptosis, usually profound ptosis, divergent sequent because the lateral rectus is the dominant now, and limitation of ocular movement except for lateral gaze. Parasympathetic palsy راح تؤدي إلى dilated pupil and defective accommodation. As you can see in picture A, there is severe ptosis with exotropia. On trying to look to the right, the left eye will not be able to move because of the paralyzed medial rectus, while looking on the left, the healthy lateral rectus is working. Now the management. As we said, the cornerstone differentiating feature between the two lines of management is the pupillary involvement or pupillary sparing. So in a pupillary involvement, usually the cause is surgical and immediate neuroimaging and neurosurgical consultation. While in a pupillary sparing third nerve palsy, then medical consultation when the causes are obvious, being an old, hypertensive, diabetic, and observation, of course, after control of risk factors. If there is no improvement after 6 to 12 weeks, again we need a neuroimaging. بس نخلي ببالنا انه من نشوف case of third nerve palsy which is pupillary sparing, نخلي بالنا to examine the patient to start with every other day for about 2 or 3 times per week حتى نكون متأكدين إنه ما راح يصير pupillary involvement later on. So when we are sure this is a medical third, then we will wait for 6 to 12 weeks with medical consultation, controlling the risk factors, and if there is no recovery, again neuroimaging. لكن pupillary sparing third nerve palsy in a young patient without obvious risk factors, then a neuroimaging again is indicated immediately. After addressing the factors causing, after management, or after trauma and the patient have permanent third nerve palsy, then we may deal with the sequelae of severe ptosis and severe exotropia with surgery, but with mild guarded prognosis. Now the trochlear nerve, the fourth cranial nerve. It is a crossed nerve. This means that the fourth nerve nucleus innervates the contralateral superior oblique. It is the only nerve that emerges from the dorsal aspect of the brainstem, specifically the dorsal aspect of the midbrain at the level of the inferior colliculus. So it is a very long and slender nerve, and this makes the nerve very vulnerable to trauma. Trauma, whether direct or indirect injury, is a common cause for fourth nerve palsy. The hallmark for the clinical features of the trochlear nerve palsy is ipsilateral hypertrophy. The characteristic clinical picture for fourth cranial nerve palsy in adults is acute onset vertical diplopia, an absence of ptosis combined with the characteristic head posture. So, for left fourth nerve palsy, the features are: number one, in a primary position, there is left hypertropia. Number two, there is an increase in the left hypertropia on right gaze due to an opposed inferior oblique. 3. There is limitation of depression on adduction, which is the action of the paralyzed superior oblique. Number 4, as we said, the head will turn where the eyes cannot, so the abnormal head posture have 3 components: head tilt to the right, face turn to the right, and chin depression. This is a patient with left superior oblique palsy. As you can see in the middle row, the left eye, have the red circle around it, is hypertropic. On looking to the contralateral gaze, on looking to the opposite right gaze, we have an increase in hypertropia. Because in this position, as you know, in adducted position, the obliques should work. We have the inferior oblique, which is the elevator in adducted position, and the superior oblique, which should depress the eye in this adduction. Because the superior oblique is now paralyzed, there is unopposed action of the inferior oblique, so inferior oblique is overacting, causing hypertropia to be increased in this position. While on looking to the ipsilateral gaze, يعني on left gaze, راح نشوف أنه there is almost disappearance of the hypertropia. Also specifically, we have to do the down gaze. As you can notice, the mid-down position or the left down position, the eyes looks symmetrical, while on right and down position, because we are now bringing the left eye in the field of action of the paralyzed muscle, because we said superior oblique causes depression in adduction. As you can see, there is obvious limitation of this depression in adduction due to superior oblique paralysis. A useful test also is the head tilt test. We said a patient with left superior oblique palsy will adapt an abnormal head posture, which is the contralateral head tilt، يعني right head tilt. شوية يسوي وياها right face turn. ليش؟ Because on right face turn the left eye will be more in abducted position، يعني راح تكون بعيدة عن ال field of the paralyzed superior oblique. And also the patient will do slight chin depression because the superior oblique, which is a depressor in adducted position, it is a depressor muscle. So the patient will ايش راح يسوي الهيد will adapt the slight depression حتى it keeps the left eye in a slightly up position, in a slight elevation. فراح يكون بهالبوزيشن هذا بهال 3 components of the abnormal head posture راح يخلي the left eye as far as possible away from the field of the paralyzed superior oblique. This is another patient with right superior oblique palsy due to right trochlear nerve injury. He is adapting a left head tilt in order to avoid the vertical diplopia. When we do him an opposite, we will tilt his head to the same paralyzed side. يعني هو مسوينا left head tilt، احنا راح نلزم راسه ونسوي له right tilt. We will demonstrate the right hypertropia. As you can see, the right hypertropia became obvious. This is what we call it the head tilt test or Palsy test. Now, causes for fourth cranial nerve palsy. In children, the congenital causes are the most common, although sometimes the symptoms may not develop until decompensation occurs. أحيانا at the brain level أكو من اللي نسميه the vertical fusional mechanisms. There is an ability for the brain to control mild to moderate cases of trochlear nerve palsy by increasing the vertical fusional mechanisms. This is a positive adaptation at the brain level. But this mechanism may decrease or weaken, so decompensation may occur in adult life. Number 2, trauma. Trauma is a frequent cause and frequently it causes bilateral. يعني يجيك typical example in RTA أو طفل أو adult دا يسوق بايسكل يقول لك الأهل وقع انطخ راسه بالصبة بالرصيف وصعدت عينه whether unilateral or bilateral. This is a typical traumatic fourth cranial nerve palsy. Number 3 microvascular والsetting حكينا نفسه old or middle aged with vasculopathy with diabetes hypertension إلى آخره. Number 4 aneurysms and tumors بالحقيقة they are extremely rare. So for an aneurysm or a tumor it is very rare, extremely rare to cause isolated fourth cranial nerve palsy. عادة تسوي combination of 2 or 3 nerves الثالث والرابع أو الثالث والرابع والسادس. So this is why routine neuroimaging for isolated fourth nerve is not required. Management for congenital or decompensated congenital is usually surgery by weakening of the inferior oblique, so working on the antagonist. Other causes for microvascular, for example, usually control of the risk factors, and for traumatic cases, usually we have to wait for spontaneous recovery after 6 months, sometimes more, and if not, again, surgical correction is the solution. The abducent nerve palsy. The abducent nerve nucleus lies in the pons. It exits the brainstem at the pontomedullary junction. Near the CP angle, near the cerebellopontine angle, it is closely related to the facial nerve, so a CP angle lesions might cause combined 6th nerve palsy and the 7th nerve palsy. It passes then alone within the cranial cavity until it enters the cavernous sinus. So as we mentioned, cavernous sinus lesions might hit multiple cranial nerves, third, fourth, the first and second division of trigeminal with the abducent. There is what is called a false localizing sign, which is specific for abducent nerve palsy. What does it mean? It means that there might be 6th nerve palsy but the lesion is not along the course of the sixth cranial nerve itself. The lesion could be elsewhere, but this lesion might cause increased intracranial pressure, and this will cause some pushing on the brainstem. Some suggest downward pushing, some others suggest backward pushing directly by a tumor or by the increased intracranial pressure. Both of these might cause stretching of the nerve as it passes on the tip of the petrous part of the temporal bone, and this causes paralysis of the sixth cranial nerve. So, increased intracranial pressure caused either by a space occupying lesion or benign lesions اللي نسميها idiopathic intracranial hypertension. Both of these causes stretching of the nerve as it passes over the petrous temporal bone and giving rise to abducent nerve palsy. This is a review for the anatomy of the abducent nerve. As you can see, the nuclei lies in the pons. They are ventral to the fourth ventricle, and this is the relation between the nerve and the bone. Then it passes to the cavernous sinus, reaching then to the lateral rectus. Causes, again, we have microvascular. We have tumors, as we mentioned, like in the picture. Cerebellopontine tumors are very common. Trauma, raised intracranial pressure, and miscellaneous causes. So how does the patient present? The patient usually complains from acute diplopia, usually horizontal diplopia, يعني صورة أبصر صورة. He have high esotropia, converted sequent, limitation of the lateral eye movement, and you might be able to notice that he will adapt an ipsilateral face turn. Why? When he have left sixth nerve palsy, so left lateral rectus palsy, he will keep his head directed to the left side in order to bring the eye to the right. So as you can see in the picture, we have left esotropia. When the patient looks to his right, he looks totally normal, while on looking to the paralyzed side, بالحقيقة he have profound and complete paralysis of the lateral rectus. Management of sixth cranial nerve palsy. Again, when the cause is microvascular, then controlling the risk factors and waiting for recovery for 6 to 12 weeks. If not, then neuroimaging is indicated. But for young patients, for children, we have to send immediately for neuroimaging because of high risk of intracranial neoplasms, whether these neoplasms are causing direct injury to the sixth nerve, like for example CP angle tumors, or causing increased intracranial pressure with indirectly causing the sixth nerve paralysis as a false localizing sign. طبعا one of the important signs اللي تمكن الدكتور to tell the patient immediately that he have increased intracranial pressure is examining the optic nerve and finding papilledema. So papilledema with sixth nerve palsy means increased intracranial pressure, but sometimes, rarely, sixth nerve palsy as a false localizing sign might occur in absence of papilledema. إذن, urgent neuroimaging should be kept in mind if any young or a child with abducent nerve palsy. Finally, for permanent paralysis or permanent paresis, after addressing the cause and managing the cause, the final treatment is surgical. The large angle exotropia, when there is paresis, يعني partial paralysis, it may be corrected by maximum resection surgery. يعني lateral rectus اللي هي الباريتك ممكن نسوي لها large maximum resection، يعني نقويها by doing resection ونضعف the antagonist, so we weaken the medial rectus ipsilaterally by doing maximum recession. This might work for paretic cases، يعني مو total paralysis. Those cases with total paralysis, the treatment should be by transposition surgery. يعني we transpose fibers from the superior rectus and from the inferior rectus, and we suture them to the paralyzed lateral rectus. This is for complete paralysis. Thanks for listening, and I'm happy to answer your questions. Good luck.